Hello there. This is your introduction to immunohematology from myself, Dr. Christine Cserti-Gazdewich. I'm a transfusion medicine specialist and an associate medical director of the blood banks here at UHN, working with Jacob Pendergrast and Lenny Lieberman, and serving as a remote associate medical director for some external hospitals, as you can see here, as well as a clinical hematologist here on consults and in clinic at UHN and cross-appointed to Mount Sinai. My bias in these roles is toward immunohematology. So I hope that you'll be interested in this content. So I have no relevant disclosures, particularly with any of the companies who make the medications used to treat the conditions that I'll be mentioning. These conditions are rare, and so that forces us to use medications in an off-label fashion because it's hard to establish the evidence base that's rigorous enough to reach labeling requirements. But that will be called out when that's the case. And unfortunately, my bias is somewhat negative towards pharmaceutical companies because of the cost of the medications when they are used on label. So this is the glossary of terms, and by the end of the session, you'll be familiar with these. You'll have the PDF of this slide deck as well to use as a reference. We won't be covering HIT or VIT. That will be covered in your thrombocytopenia session. This is a very cool paper that got published in Scientific American. This is actually the end of what's a larger Sankey diagram. And you can see that it's got a rank order or hierarchical frequency-based listing of autoimmune conditions, giving you little capsules with the distribution in patient gender and typical age of onset. And you can kind of close up on the immune cytopenias in the middle of this figure and see that ITP does outrank anti-red cell autoimmunity or anti-neutrophil autoimmunity. And if you tilt the hemogram, the natural ratio of cells in our circulation have it that red cells are obviously more abundant than platelets and white cells, respectively. So the most abundant cell type in the blood stream is not the number one target for these occurrences of autoimmunity. So platelets, for whatever reason, are more commonly taken down by the immune system than red cells or neutrophils are. So when you think about immunoheme entities, you can organize these as autoimmune cytopenias or alloimmune cytopenias. And simply think about it as, what are the three major categories of cell types circulating in the bloodstream? So when it comes to attacking the red cell biomass, those by definition are autoimmune hemolytic anemias, and those can be warm or cold. Cold autoimmune hemolytic anemia, in turn, breaks down into cold agglutinin syndrome versus paroxysmal cold hemoglobinuria, and we'll talk a bit more about those momentarily. There's drug-induced immune hemolytic anemia, not to be confused with drug-induced oxidative hemolysis, which is a biochemical mode of erythrodestruction rather than immune-mediated. And then thrombotic microangiopathies, typically mechanical hemolytic anemias, are often regarded as non-immune forms of hemolysis, but deeper at their root, there sometimes is an immune etiopathogenesis, such as when the body raises inhibitors or neutralizing autoantibodies against the lawnmower protein, von Willebrand factor, cleaving metalloprotease, or ADAMTS13. So the root cause of TTP upstream actually is an autoimmune pathology, and we know that because we throw steroids and other immune suppressants at that condition. So downstream, when there's mechanical reasons for red cell lysis, that particular mode of red cell destruction is non-immune, but the condition still at its root is immune. Now, there aren't as many ways to organize thrombocytopenia or immune thrombocytopenia because we don't have as many tests. We don't thermodynamically rearrange ITP into warm versus cold. If we had a way to organize ITP, it would probably be on the basis of T versus B cell mediated ITP, because we know that those are two categories of immune destruction, but we don't have tests to distinguish those two. And we don't have the platelet equivalent of a DAT. And you may wonder, why are there so many ways to organize immune hemolysis? Well, it's because the blood bank has naturally been the venue by which we look for red cell intolerance. And that's the basis for how we cast out blood that's labeled as cross-match compatible or not. So we have the tools by which to detect red cell sensitization with antibodies, but there isn't such a culture or means of determining platelet cross-match compatibility with oneself or with a platelet product. So platelets are handled very differently from how red cells are in the blood bank in terms of our stringencies for release. When we have immune system activity against white cells, interestingly, the cell type that gets picked on by the immune system are the neutrophils. Now, that's very rare to have autoimmune neutropenia, but it is described. So it is somewhat ironic that the immune system has the power to pick on itself, but once in a while, autoimmune neutropenia or autoimmune granulocytopenia does occur. If you have 2 or more immune cytopenias occurring, ITP with immune hemolysis, that earns the title Evans syndrome. Now, Evans syndrome can be all 3 immune cytopenias: immune neutropenia, immune thrombocytopenia, immune hemolysis, or it can be any other combo of 2, and it can be any sequence of autoimmune cytopenias. They don't have to occur synchronously to get the title. And we distinguish this fact with a title not because we want to glorify Evans, but because anyone whose immune system has been able to pull off intolerance against more than one cell type in the bloodstream subtends a higher pretest probability of some interesting driver conditions. So in pediatrics, Evans syndrome is likelier to be driven by conditions such as common variable immunodeficiency or ALPS, autoimmune lymphoproliferative syndrome, or 22q deletion syndrome. So we're getting into some pretty exotic territory here, but this will be the job of a staff hematologist to take a step back and consider. In older patients, so in adults, what you're likelier to see at a hospital like ours is Evans syndrome being driven by an underlying lymphoma. So a lymphoproliferative disease is a likely driver if someone has pulled off Evans syndrome. So we have to look a little more aggressively for things like lymphoma if this has occurred. Now let's think about alloimmune cytopenias. Allo means self versus non-self. And so if you have 2 parties going at it, there can be 2 different vectors of attack. And that could be a graft versus host or a host versus graft response. So the differential diagnosis for graft versus host polarities of circulating blood cell destruction can be the penultimate, where you have trilineage takedown, and that's marrow destruction, a pancytopenia from graft versus host disease. So we're used to seeing graft versus host disease after BMT, and the bone marrow itself is usually healthy because the passenger lymphocytes causing graft versus host disease cruised in on the stem cells that were meant to repopulate the marrow. So I'm not talking about BMT GVHD, but I'm talking about incidental GVHD that occurs after a red cell or a platelet transfusion, a transfusion-associated GVHD, or a solid organ transplant-associated GVHD. These are situations where you did not get seeded with a bone marrow populating stem cell population. And so when you get GVHD in these 2 situations, the bone marrow is getting destroyed by the proliferating lymphocytes. Okay, so you have proliferative engraftment of viable lymphocytes that have cruised in on the coattails of a cellular blood product like red cells or platelets, or within the lymphoid biomass of an allograft that's been transplanted. So this will present with fevers, pancytopenia, biochemical hepatitis, and mucositis from mouth to anus. Okay, so this is a very protean multi-system presentation. And so it is one that we need to consider at an institution like UHN because we are North America's most active or highest volume solid organ transplant center. We do more than 600 solid organ transplants per year here, more than UCLA and UCSF. And so if you get a referral for pancytopenia in a post-BMT patient, it is something to consider. Now, transfusion-associated graft-versus-host disease shouldn't happen because we have mitigation. And the mitigation that we have to prevent transfusion-associated graft-versus-host disease is the irradiation of the cellular blood product. Now, that needs to be called for. Irradiation is not something that gets done on every cellular blood product. It is a personalized mitigation strategy that has to be ordered in those who are at risk of TA-GVHD. And that raises the question of who are these patients who earn this blood product modification. So put simply, these are people whose immune systems don't have the power to fight off or recognize viable lymphocytes that have the risk of engrafting within them. And so that's very young immune systems. So intrauterine transfusions or very low birth weight infants, which are essentially ex vivo fetuses. Transfusions to very immature immune systems are at risk of engraftment. Cancers of the immune system, specifically Hodgkin's lymphoma, is a risk for transfusion-associated graft-versus-host disease. And certain malignancies that get drugged in a way that impairs the immune system of the host are at risk. And so there's a very long list of drugs. The pharmacy gets us a list every day of people who are taking them. But immune disabling drugs are agents such as fludarabine, antithymocyte globulin, bendamustine, and so on and so forth. So if your patient is on a drug that engenders that risk, we need to advocate for them and ask for irradiation. Fludarabine is the preparatory drug for many cell therapies, and therefore cell therapies such as CAR T cells or tumor infiltrating lymphocytes, you can assume quite confidently that any cell therapy patient is going to need irradiation of their cellular blood products because we've deliberately disabled their capacity to reject the cell therapy we're about to infuse, and therefore they may not be able to reject lymphocytes that are coming in from blood transfusions. So you don't want them to die of GVHD after you've given them, a $400,000 life-saving CAR T cell infusion. All right, so there's drugs, Hodgkin's disease, immature immune systems, and finally, a risk factor is congenital immunodeficiencies. Okay, so people who are born with athymia or poorly developed thymus glands, again, that occurs in 22q deletion syndrome, formerly known as DiGeorge syndrome, velocardiofacial syndrome. People with other kinds of congenital immune deficiencies, specifically T cell immune deficiency with Scott-Aldrich syndrome. There's a long list. So if your patient has an important T cell based immune defect, congenitally speaking, they need irradiated blood products. I specifically say cellular blood products. Plasma is not included in what needs irradiation because the act of freezing and thawing shatters cells. There was no cryopreservative put into plasma to deliberately make cells viable again on thaw. So the thermodynamics of freeze thaw take care of that risk for us. So you don't have to irradiate plasma, but cellular products may have viable lymphocytes. Lymphocyte viability lasts for about the first 14 days of storage. Okay, so that's GVHD. Now, passive hemolysis. It's possible to have a hemolytic transfusion reaction after yellow stuff. So IVIG or platelets can cause a hemolytic transfusion reaction. And the mediator of hemolysis in this case are the ABO antibodies that may be contaminating the product. So IVIG comes pooled from the plasma of tens of thousands of donors. And that therefore represents tens of thousands of donors with all the ABO types. And we know that the only people who don't have antithetical, anti-A or anti-B in their plasma are group AB people, and that's only 4% of the population. That means 96% of people, everybody else who's not group AB, O's, A's, and ABs, have ABO hemolytic antibodies in their plasma. Group O people have anti-A and anti-B. Group B people have anti-A. Group A people have anti-B. You take tens of thousands of plasma bags. In the fractionation industry, when we generate purified protein products like albumin or IVIG, when we make IVIG, we're extracting the immune globulins. And it's an unbiased extraction. We collect all the antibodies from tens of thousands of people. And that therefore includes some anti-A and anti-B when you add it all up. So every bottle of IVIG that you spike will drizzle into your patient some potentially hemolytic anti-A and anti-B. So that's relevant if you're giving IVIG to any non-O recipient. It would be wise when you get informed consent for an IVIG transfusion to consider out loud with your patient to be conscious of what their blood type is so that you can specifically counsel them on this risk. Now, the risk is roughly a third of people getting high dose IVIG who are not blood group O, the A's, B's, or ABs, high dose IVIG, but a third of those individuals will have some evidence of hemolysis, and a third of that third will have significant hemolysis to the point they may even need a transfusion. And the correct blood type to support them with if they're hemolyzing after IVIG is not type-specific blood because you're just bringing in more vulnerable cell type, but rather to just give them group O blood during that hemolysis support period. This is a finite or ultimately self-resolving situation because there was a finite amount of antibody confined by the boundaries of that IVIG bottle. So it will land on the red cell, the sensitized red cell will get cleared. That antibody doesn't reproduce. Okay, so you haven't infused lymphocytes that are a factory in secreting hemolytic antibodies. You've secreted a finite amount of antibody. Now, in platelets, why would you have ABO-mediated hemolysis in platelets? Well, it's certainly not the platelet cells pulling that off. Platelets don't have nuclei or brains. They're not very smart. They're cellular bandages. They do their thing. They're not the agents of hemolytic destruction. So what in a platelet bag is doing that then? Well, it's the plasma that they're suspended in. So platelets are suspended in plasma. If you look at a bag of platelets, about 300 cc's, only about a milliliter or so of that entire bag of platelets is actually the cells, the platelet cells. The rest of that enormous bag is the plasma that the platelets are suspended in. That's until we use platelet additive solution. And we don't have that yet in Canada, but that's coming. And so plasma therefore carries the risk of carrying the ABO antibodies that are in accordance with the blood type of the contributing plasma donor. So if you're hanging a bag of Group O platelets, the Group O plasma in that Group O platelet product has some anti-A and anti-B in it, and it can cause hemolysis. So you can think about this as the GOP is deadly. Okay, so Group O platelets have plasma from a Group O person, and that can cause hemolysis to a non-blood Group O recipient. We do some mitigation here in the U of T affiliated teaching hospitals. So we will check the titer or the strength of the anti-A and anti-B. And if it's a high strength contamination with hemolytic antibodies, we will do what's known as a plasma volume reduction or a PVR. And so we'll be casting up to the floor a deflated looking bag of Group O platelets if we have to cross the ABO barrier and give a Group O platelet to a non-O recipient. Now, TRALI, transfusion-related acute lung injury, used to be the number one cause of transfusion-related death. It's dropped down because we've mitigated the risk of this. I've put this on the list of graft versus host cytopenias because this non-cardiogenic flash pulmonary edema called TRALI, a transfusion-related acute lung injury, has as its cause usually donor leukocytes that in this bad luck situation are specific to or cognate for the leukocyte antigen type of the recipient who is getting that blood product. So anti-leukocyte antibodies, if they land on the HLA system of white cells or human neutrophil alloantigens, if they are cognate, those sensitized leukocytes can get phagocytosed or cleared, and you could see a post-infusion passive leukoagglutinin-mediated leukopenia. Now, usually what you see in the infusion of donor leukoagglutinins is trolley, and the mechanism of trolley is that the leukoagglutinin lands on white cells that are sequestered in the lungs of the recipient. You're getting a transfusion, anti-leukocyte antibodies are being infused through your vein, venous blood comes to the right side of the heart, pumps into the lungs. The lungs are the first high surface area vascular bed that any venous material is going to see, and that includes DVTs that become PEs. If you are infusing anti-leukocyte antibodies, by bad luck, they're going to land on white cells in the lungs. And that ligation is so excitatory that the leukocytes in the lungs will degranulate and release their microbicidal arsenal, the stuff that's reserved for fighting pneumonia. And that vast explosion of leukocyte contents causes basement membrane damage for the capillaries that encircle each alveolus. And so you get a major flooding or capillary leak, proteinaceous, if not sometimes bloody bronchorrhea. So alveolar flooding, and this explains the ARDS picture that you'll see on chest radiography in the dyspneic transfusion reaction due to trolley. If you suspect a trolley, I would say it's a moral obligation to call the blood bank, because obviously if one product can do this to a person, well, the other co-components that came from the original good intent of that blood donation can cause harm to other people. So we need to know about this in the blood bank because it's high stakes. This is about quarantining co-components and informing Canadian Blood Services about a potentially dangerous donor that may need to get deferred from future donations, if indeed the case pans out as a true trolley. I want you to report any suspected dyspneic transfusion reaction, any febrile transfusion reaction, any suspected bacterial contamination of a blood product. These things are all reportable events to the blood bank. And I don't want you to be afraid of reporting any suspected transfusion hazards to the blood bank because it won't increase your workload. In fact, we incentivize reporting by taking care of the investigation ourselves. So you will not work harder as a result. You don't have to do more things. Okay, we have investigation, human resources, and we will investigate because we also have an interest in making the blood system safer as a result of your concern. So please report ad lib. It is a good thing to over-report rather than to under-report. So TRAIN or TRAIL are transfusion-related alloimmune neutropenia or transfusion-related alloimmune leukopenia, courtesy of the leukoagglutinins that often ride with trolley. If you have a person in respiratory distress after a transfusion and you see that their white count has crashed after or with that reaction, you're going to be even more suspicious that trolley was the cause. Okay, so let's flip over to host versus graft. So this stuff should be a little easier or a little more intuitive. If I give a patient a red cell and they have a rejection event of that red cell transfusion, that's an acute or a delayed hemolytic transfusion reaction depending on the timing. So acute if it's within 24 hours, delayed if it's after a day and within a 2 or 3 week period of that transfusion. So that's obviously your host's immune system rejecting what we've given. If a person is screen positive, they're armed with the material that could reject a transfusion. And so that can happen if our transfusions weren't perfectly matched for someone who was historically screen positive. We may not have known about the antibodies. You realize that our patients are more portable than their laboratory or health information is. And so sometimes this is a consequence of healthcare fragmentation. But people who have antibodies, people who are screen positive ever in the past or currently, deserve higher fidelity blood matches to evade this risk. People who are screen positive are not just at risk for hemolytic transfusion reactions, but also hemolytic disease of the fetus and newborn. So if you have anti-red cell antibodies that could reject future transfusions, those antibodies could also reject the blood of the fetus within a person who's pregnant. So it's the reason why we are very conservative in triggering transfusions in iron deficient menorrhagic individuals who could otherwise just recover with iron replacement therapy. So we need a pretty intense bar of anemia, hemodynamic instability or very significant symptomatology to justify transfusion to a person with childbearing potential, because they can alloimmunize and the antibodies that they develop could become cognate with the blood type that future pregnancy is fated to bear. So you don't know what detailed blood type your future fetus is going to have. And IgGs that can cause hemolysis are small enough to cross the placenta into the baby. That's a good thing most of the time because maternal immunity does come into the fetus's bloodstream. And after you cut the cord, there's no more of that good maternally derived preformed IgG coming into the baby. Hence, you begin a vaccination schedule. But the same applies to the harm of having bad antibodies, ITP antibodies, immune hemolytic anemia antibodies, antibodies against red cell alloantigens that could be peculiar to your future baby's blood type. Okay, on the platelet side of things, you can similarly reject a platelet transfusion. So that's platelet transfusion refractoriness. Usually the basis of immune-mediated platelet transfusion refractoriness is HLA sensitization. HLA is a system that's very provocative, very polymorphic, very easy to make antibodies to. And it's what makes finding stem cell matches for patients so hard when they need a BMT. So platelets also express HLA. And once in a while, if you have an HLA sensitized recipient, they could be knocking down their platelet increment serially. Now, the expected increment after a platelet transfusion is about delta 30. And our general rule to suspect immune-mediated platelet transfusion refractoriness is someone whose platelet transfusion increment doesn't go up by delta 10. So if it's a delta 10 or less, and you can be more specific about this, delta 10 or less if you do the blood work within an hour of the completion of the platelet transfusion. That's going to be a lot more specific to revealing the possibility that your patient has immune-mediated platelet transfusion refractoriness. If your patient fails to increment by delta 10 an hour after their platelet transfusion, they deserve a workup. And so the workup there is testing for antiplatelet antibodies. Okay, so HLA antibodies account for 90% of those cases, and that's the first level test in the serial test option. After HLA antibodies, it's possible to have developed HPA antibodies, antibodies within the human platelet alloantigen system, the membership of which includes molecules like glycoprotein 2b3a and glycoprotein 1b9. In cardiology, you may have learned about these molecules because we have drugs opposing glycoprotein 2b3a to block platelet aggregation. So 2b3a is the platelet receptor that binds to fibrinogen and allows platelets to interlink and to aggregate and to cause that 3D bloom that can block a coronary artery and cause ST elevation, myocardial infarction. So hence we have 2b3A inhibitors as anti-platelet aggregation drugs. So immune systems once in a while can make antibodies to subtle differences in platelet alloantigens. Okay, so someone else's version of glycoprotein 2b3a might be different from your patient's, and they may make antibodies against those. What's interesting about HPA sensitization is that it can boil over into a syndrome called PTP, or post-transfusion purpura. So post-transfusion purpura exhibits this unusual phenomenon of bystander platelet destruction. So you don't just destroy the platelet increments worth. Okay, it's not just a matter of your platelet transfusion increment was 0. It's that you get into negative platelet counts. Okay, so a person who triggered a platelet transfusion at a count of 30 might not stay 30, but drop to 20 or 10, or be left with uncountable platelets. So the dreaded less than 3, which is the lower limit of detection in our machines. So there are ways to test for the formation of these antibodies, HLA or HPA antibodies. Any questions, you ask your staff logistically on how to do this in EPIC. Now, if a person who could get pregnant has HPA alloantibodies, those likewise can cross the placenta and cause the platelet equivalent of HDFN, which is fetal neonatal alloimmune thrombocytopenia. Now, if you have autoimmune cytopenias, many of them are idiopathic. 50 to 80% of autoimmune cytopenias are idiopathic. But the converse of that is that some of them have drivers. Okay, so that means secondary immune cytopenias if it's not a primary idiopathic process. So always look for whether or not this is a secondary case and whether or not there's an underlying driver illness, because treating the root cause or identifying an additional pathology that someone else may have missed may benefit your patient. So look to see if they're now meeting criteria for lupus, or look to see if they have a flavor of underlying rheumatologic or connective tissue diseases, IBD counts here. Okay, so this could be an extraintestinal manifestation of Crohn's disease. Paradoxically, you have to look for immune deficiencies in people who are capable of pulling off autoimmunity. Okay, so if they've never been tested for HIV and they have a risk factor for it, do the test. If they are presenting with Evans syndrome, look for common variable immunodeficiency, look for Bruton's agammaglobulinemia or other congenital immune deficiencies. So if you're unsure of the list here, have a conversation with your staff when you're reviewing the case. Lymphoproliferative diseases. Okay, so autoimmune cytopenias can be a paraneoplastic emanation of lymphoma. And the lymphoma most famous for doing this has its blood film here. So CLL, chronic lymphocytic leukemia, although it sounds like a leukemia, it's a peripheralizing lymphoma. It's a leukemic lymphoma. So this is a lymphoma that's very good at presenting self-antigens to the T cells and the immune system. And you can have, stage 0 CLL or stage 1 CLL, or have a person with a CLL-like monoclone who doesn't even meet the definition of CLL, who's pulling off life-threatening autoimmune hemolytic anemia. So this is a clonal cell population that behaves in an aberrant antigen presenting cell fashion and convinces the rest of the benign immune system to generate antibodies to take down a particular cell type. So it sounds bizarre, it really is, but CLL is really capable of co-presenting with ITP or immune hemolysis. So look for lymphoma in people presenting with immune cytopenias. Non-lymphoid malignancies can do this too. So sometimes we get paraneoplastic, ITP or immune hemolysis in ovarian cancer or lung cancer. But what's really taking off and what we have to be very conscious of today is that people on PD-1 blockers or tumor immunotherapies unleash all kinds of autoimmune storms. So any solid organ cancer patient who is taking tumor immunotherapy may be presenting with immune cytopenias, and the pembrolizumab that they're on is potentially blameworthy in your differential diagnosis. Finally, infections can be inducers of immune cytopenias, EBV or CMV, either the first-time infection or the reactivation thereof. We know that mycoplasma pneumonia can cause cold agglutinin disease. So there are many infections that can precipitate different kinds of immune cytopenias. And especially today in the pandemic, we appreciate that COVID, the natural infection, or its vaccine can cause immune cytopenias. And these would be reportable events at a pharmacovigilance level. So we do want to hear, not that we want to arm the anti-vax movement, but these are really important events to recognize and to label appropriately. Now, let's think about antibody isotypes. The relevant antibody isotypes. Every antibody starts off as an IgM, and then eventually it isotype switches to IgG, which is the monomeric form. But IgMs in their primitive state can cause disease. You can see here in this picture that IgM pentamerizes. And if an IgM is red cell specific, that pentamerization is what draws the red cells together into agglutinates. So IgMs can cause agglutinative hemolysis. And we call this a cold antibody because the molecule organizes or does even more of this pentamerization work the more heat you take out of the system. So you know that from high school chemistry. If you cool down a supersaturated solution, it's going to crystallize more. So you get more and more of this viscosity inducing or agglutinative activity of IgM under cold circumstances. So this is why IgMs are called cold antibodies. Waldenstrom's macroglobulinemia, if you are suffering from this clonal condition and secreting out a lot of clonal IgM, this IgM, if it's pentamerizing, can increase the serum viscosity and cause viscosity-related pathologies. Cryoglobulinic vasculitis, precipitating on the endothelium, fixing complement, could potentially do even more of this under cooling conditions. So this makes us very conscious of what temperature we hold the patient at and with our prescription for keeping warm, so to speak. Now there's a thermodynamic or physical chemical implication of pentamerization, and that's the fact that because pentamers as a quaternary structure are not small enough to cross the endothelial wall or basement membrane, these tend to be intravascularly confined, and so that makes it easier for us to pull these out by apheresis. Conversely, IgGs, which are monomeric, cross the vascular barrier, and that's good news for the immune system if we're fighting an infection. But if you have a pathologic IgG, it means that the volume of distribution for this is harder to get rid of. So the vacuum that is apheresis needs to work harder and maybe daily for many days on end if you have an IgG causing pathology. So TTP, if you have an IgG against ADAMTS13, one apheresis ain't going to cut it. You're going to have to do quite a bit of plex to get the disease under control until the immune suppressants kick in. Okay, this is the pie chart for the ABIA distribution in the population. And you can see that group O is the commonest blood type on Earth, followed by group A and then B, and then AB as the least common blood type. And you can see listed in the boxes the reciprocal isoagglutinins, the antithetical plasma antibodies that follow what is known as Landsteiner's law. These antibodies exist because we naturally make antibodies against A or B-like structures that we see in our microbiome as we get seeded in early life. So A and B antigens exist across many life forms in our evolutionary history. So even prokaryotes or the bacteria, our commensal microbiome, do carry A and B-like structures. And if you're group A, you're not going to make an antibody against the A antigen in bacteria because you possess it and you're tolerant to it. But if you've not seen anti-B, you won't be tolerant to it. And so in early life, we make antibodies. There's some evidence that some of these antithetical antibodies may be beneficial in neutralizing germs that happen to carry those particular sugars. So it is what it is, but this does put people at risk of hemolytic reactions. And this is why this is the most commanding blood group antigen system in blood banking. It's because people come pre-armed with hemolytic antibodies, so you can't cross the ABO barrier. It's not cool to give a group O person group AB blood because they can hemolyze to death from that. So we very much respect the ABO rules and have compatibility tables for who can get what. So the universal red cell type that anyone can get is group O because it's got no A or B antigens on the red cell surface. And the universal plasma, because it doesn't have hemolytic anti-A or anti-B in it, is group AB. So now in 2022, I need to update this. We're at 44 blood group antigen systems. There's a lot of diversity in the red cell proteins that are expressed on the surfaces, and we can pick up on those subtle differences and make antibodies against those polymorphisms. And so this is why we do the screen in the group and screen. It's not enough to give ABO suitable blood, but we're always on the hunt for what alloantibodies a person may have made to other red cell antigen systems that we don't match for up front. Okay, so everybody gets ABO RHD matched blood, but there's no guarantee that you're not going to be offended by something else outside of the ABO system in a blood transfusion. So every transfusion is going to show to a person's immune system something that they've never seen before until we hit the era of super personalized medicine, or we're able to transfuse your patient with ex vivo cloned bioreactor blood from their own stem cells. So clearly we're not there yet, and all blood transfusions are allo sourced or homologous blood materials. So even if you're hanging an ONEG unit of red cells to a person in a massive hemorrhage protocol while you don't know their blood type, they could still attack another point, okay? So that's why we do blood bank testing. Your blood bank specimen in EDTA tube is what we can do grouping, the full group and screen. The screen is also known as an indirect Coombs red cell antibody screen. We can test a DAT on the blood bank compatibility specimen. We sometimes call this a type and cross or a cross and type. One of the problems in nomenclature and inducing confusion in learners is how many different names the blood bank sample goes by. Some people call it the cross-match sample. So what do we do with this? Well, in the blood bank, we spin it down, and when we pipette up the red stuff, we characterize your patient's cell surface identity to declare what their blood type is. And so that's called forward ABO and RHD typing. And if we want to go beyond the norm and prophylactically antigen match or give extended antigen match, super matching work, we will phenotype for those minor red cell antigens so that we emulate your patient's type. I mentioned that we can do a DAT on this sample, and what the DAT is looking to see if you have IgG or complement smothering the red cell as a sign of an immune attack event in your patient. So you order the DAT if you are suspecting immune red cell destruction. Okay, and that's called a direct Coombs test or a direct antiglobulin test. So we use a polyspecific reagent for that, fishing around for complement or IgG. When we do indirect testing, that's when we're pipetting up now the plasma. That's us looking to see if you have anti-red cell antibodies from antibodies still unattached to things, so free-floating, lying in wait. So we're looking for the antibodies, alloantibodies that could bind to future served red cell units. We therefore use reagent red cells to see if there's anything that your patient's plasma is hostile to or wants to land on to destroy. We will confirm your patient's reverse or back type to see if they follow Landsteiner's law. So ABO typing involves forward and reverse testing, so to speak, and that indirect Coombs test for minor red cell alloantibodies. So we're using a Coombs reagent that is IgG focused. And when we run your patient's plasma against reagent red cells, we call that a screen. And when we run your patient's plasma against the candidate red cells, we call that a serologic crossmatch. And again, this is monospecific. Now we're only interested in seeing whether or not it's IgG that's landing on the screening cell or the candidate unit for cross-matching. Now, the challenge of hemolytic anemias is that they're uncommon, but that there's many ways to hemolyze. Our way to organize this is it intra or extravascular? Intravasculars are non-immune events and extravasculars are immune events, generally speaking. Typically, intravascular hemolysis will look like broken red cells, and we call that MAHA in our technical language, so microangiopathic hemolytic anemia. Extravascular hemolysis, usually immune-mediated, breaks down into auto versus allo versus drug. And autoimmune hemolytic anemias are warm versus cold, depending on if it's IgG or IgM. And alloimmunes are active versus passive. So coming from the host's immune system destroying a product, or the product coming in to land upon the host red cells. Passive immune hemolysis being those yellow stuff scenarios of IVIG or plasma in a platelet transfusion causing a hemolytic reaction of patient red cells. So if you suspect hemolysis, the first step is to prove that it's there. What is the lesion and where is the lesion? So what is the lesion? The way we figure this out is by evidence of laboratory hemolysis. A hemoglobin that's dropping faster than what bleeding can account for, but there's no bleeding. Peripheral blood film changes. The plasma in a spun sample, the plasma may be pink tinged and look like there's been red cell breakdown in the bloodstream. So plasma should look yellow, but if it's looking pink or red, that could be a sign of hemolysis for whoever's managing the specimens in whatever lab. So you can call the lab to make a blood film for you or to ask what the plasma looks like. But generally speaking, we gate on biochemistries. So is there hyperbilirubinemia? Is there a high LDH? Is haptoglobin scavenged out to the point of depletion or low levels? So haptoglobin is the shield that carries plasma-free hemoglobin away so that it doesn't do damage, because plasma-free hemoglobin is toxic. That's why in our evolution we developed a scavenging molecule for it. So you can quench out your scavenger and be rendered hypo or ahaptoglobinemic, courtesy of hemolysis. The combination of a high LD with a low haptoglobin is 90% sensitive for hemolysis. And urinary hemosideruria or pigment nephropathy, starting to get renal damage, might be a sign if there is concomitant anemia. Now, things that can mimic hemolysis are hematoma products being resorbed, so that can recapitulate hemolytic biochemistries, even though this actually was a bleed in retrospect. Or a person with liver disease can have a high bili, a high LD, and be undersynthesizing haptoglobin and be having esophageal varices with a GI bleed. So just be aware that liver disease with hemorrhage can exactly look like hemolytic anemia. So we do need to look at these cases carefully to make that distinction. So to get to what is the lesion then, that's this table here. So the two most important tests to establish whether it's intra versus extravascular is your blood film and your DAT. You'll see schistose and a negative DAT in intravascular versus spherocytes, extravascular, the E's lining up there, and a positive DAT. With intravascular hemolysis, your hemolytic chemistries are also a little more exaggerated because the eye of the needle is entering the compartment that the situation is actually happening in. If you have extravascular hemolysis, it's a bit sheltered. It's occurring within the mouths of phagocytes in the spleen. So there may not be as much spillover of the indicator biochemistry into the blood space. This is a great paper, Guillot et al. Hemolytic anemia is going beyond the scope of this lecture. I'm just talking about the immune modes of hemolysis, but there are congenital and acquired immune and non-immune ways to hemolyze. And so this is a more comprehensive paper on the approach to hemolytic anemias in general, if you want to go that far. So let's talk a little bit more about immune hemolytic anemias. So these are rare. About half of these are idiopathic. The other half are due to instigators mentioned earlier. Most immune hemolytic anemias are warm. But about 35% of them are cold, and the vast majority of cold immune hemolytic anemias are cold agglutination. Okay, only a small minority of cold hemolysis is not IgM based, but due to a Donath-Landsteiner paroxysmal cold hemoglobinuria. So that's what spherocytes look like in warm. And to say a little bit about the DAT can be either truly negative or, be aware of this trap, falsely negative. So if it looks like a duck and walks like a duck, if you think that it is immune hemolytic anemia, but the DAT is negative, do not be fooled, okay? You need about 500 IgG molecules on the red cells for this test to come out positive. And you need about 1,000 molecules of complement to detect a complement-mediated hemolysis. So just be aware of that limitation in your SNOUT and SPIN rules. Okay, a high sensitivity test allows you to rule something out, but this test has a 90% sensitivity, so there's a 10% failure rate here. However, if your test is positive, we will resolve in the blood bank as to why it's positive. So we will determine if it's IgG or complement or both that's deposited. If you have an IgG positive DAT, then that indicates a warm immune hemolysis. IgG is 37 degrees active. It's the Cadillac. It is warm immune hemolysis. Okay. If you only have complement as the tracer on your red cell, this is a red flag for cold mechanisms. So C for complement, C for cold. The cold immune hemoleukinemias are really good at recruiting complement onto the red cell surface, and this ultimately becomes the mechanism or means by which cold immune hemolysis actually does its harm. So a complement positive DAT is suspicious for cold mechanisms. Now, to make it even more interesting, you can have both. Okay, and so if you have both IgG and complement positive DAT, that could reflect a mixed warm cold immune hemolytic anemia, or it could be a warm immune antibody and IgG that is capable of fixing complement the way cold antibodies like to do so. Sometimes we only pick up the complement that the IgG recruits, and that can be a complement positive DAT in a true warm immune hemolysis. So if this gets confusing, you talk to your staff or your transfusion medicine physician. We're on call 24/7 to support the hematology consult service. We can help explain the meaning of these test results. Okay, so again, spherocytes. The warm autoimmune hemolytic anemia patient is incompatible with themselves, and therefore, no surprise, they're going to be screen positive. They're going to look like they're offended by every screening cell. Every screening cell looks incompatible with them because they're incompatible with themselves. Okay, these are self-haters. It's kind of like misanthropes. You can't love others unless you love yourself. And if you're a self-hater, you're going to hate everything else externally with equal rigor. People with a warm autoimmune hemolytic anemia will have a positive DAT. And when we pull the antibody off of those red cells, they, in that solution, when we work with that in the same way that we worked with the plasma, will look like they are hostile to every red cell type. So this is a person whose plasma or eluded DAT antibodies are pan-reactive. So this is often a diagnosis picked up in the blood bank. Okay, and this will be signed out in the results of your DAT testing. Now, let's talk about cold immune hemolysis. So again, two kinds, cold agglutinin syndrome, those IgMs and their pentamerization account for the agglutination that you see on your blood film. The test name for the order here is a cold agglutinin screen. And if you have a complement positive DAT but no agglutination, no IgM to account for this, then it may be that very rare form of immune hemolysis called paroxysmal cold hemoglobinuria, not to be confused with PNH or paroxysmal nocturnal hemoglobinuria. Two very different conditions, even though they have almost the same name. So here, this is an IgG that is fixing complement, but it's capable of inducing hemolysis. And so what happens is under cold temperatures, the IgG binds, it recruits some complement, it then dissociates off of the red cell and leaves only complement to achieve the hemolysis. So this is also known as a biphasic hemolysin, and this is what's happening. So there's antibody fixation and then complement action taking over. The test name for this is the Donathan-Landsteiner, and so this is EPIC orderable. And if you have any questions, call your staff or one of us in the blood bank for help. PCH can sometimes have as a giveaway on the blood film visible erythrophagocytosis, so you can see nucleated leukocytes phagocytosing red cells. The differential diagnosis for complement sensitization is here. On the right, you can see the complement activation cascade, and the punchline is a hole punch, the membrane attack complex in the cell that's had the complement cascade activated upon it. So membrane attack complexes are the modes of cell destruction in PNH as well. This is a harmful process if it's happening. So complement activation is a hazard. We think about it all the time in medicine. And if you have a complement positive DAT, the differential again are your cold immune hemolytic anemias, PCH or cold agglutinin syndrome. A drug-induced immune hemolysis can sometimes have complement on the red cell surface, and PNH or paroxysmal nocturnal hemoglobinuria. And that is an emanation of a clonally acquired stem cell defect where all the descendants of that somatically mutated clone have problems with dealing with complement activation. So people with PNH lack CD55 and CD59, the decay accelerating factor or the membrane inhibitor of reactive lysis. So these are complement cascade controllers. So these stem cells, when they differentiate, become defective at handling complement cascades, and therefore they lyse apart, and you get hemolytic thrombotic cyclic pancytopenia in PNH. Okay, drug-induced hemolytic anemias. Many different drugs can cause red cell takedown, and that can be a bystander effect. But the bottom line here is that you want to stop the drug that's invoking this process. It doesn't matter what the cartoon stereochemistry is for this binding, but it's that unfortunately there are drugs that can cause or incite an antibody that ultimately downstream takes the red cell down. So this is a list of drugs that can cause drug-induced immune hemolytic anemia. You can see piptazo in green because we use a hell of a lot of it. So somebody who is starting to hemolyze a few days or a couple of weeks after starting a new drug could actually have drug-induced immune hemolytic anemia. This will show up as a positive DAT, but when we do the eluate studies, they will pop out negative because the reagent red cells that we're running the eluate against aren't taking the drug that your patient is taking. And so a positive DAT with a negative eluate is a big red flag for a drug-induced immune hemolysis. So I hope that if you suspect drug-induced hemolytic anemia, you're talking to your staff about it when you review the consult, and you and your staff are looking at the remarks on the eluate on the DAT. So a DAT report doesn't just tell you positive or negative. It's going to give you some narrative details on what we saw on the eluate. Was it pan-reactive to indicate a warm autoimmune hemolytic anemia, or was the eluate negative to suggest a drug-induced? So not to be confused with drug-induced immune hemolysis is drug-induced oxidative hemolysis, and that's from people who have G6PD deficiency, because G6PD is an X-linked gene. You knock out your one X-linked G6PD, you're going to see this more in people who are chromosome XY or males, generally speaking. Okay, a female, though, who is double hit on both of her X chromosomes could present with G6PD deficiency related oxidative hemolysis. So these are different drugs. These are oxidative. And obviously we have oxidation handling pathways in the red cell to deal with the oxidant stress of carrying iron and oxygen around. The sign on a blood film that the mechanism of hemolysis is oxidative is that the cells literally look like they've been carbonated. So you will see bites and blisters. So this is a very bubbly looking blood film in oxidative hemolysis. Hyperhemolysis is when, after a transfusion, your post-transfusion hemoglobin is even lower than what you triggered at. And so this is an emergency. This is an immune catastrophe. These patients have high case fatality rates, and it's hazardous to transfuse them even though the temptation is high if your hemoglobin is even lower than where you started. Okay, but this was the root cause of the problem. So we really do our best to avoid retransfusing these individuals due to the high risk of recurrence or exacerbation. And so we need to shut off this immune storm. Okay, and we do this with very high dose pulsed steroids, kind of like the doses you use in acute demyelinating encephalomyelitis. You'll be giving about a gram of Solumedrol, and you'll be giving IVIG. But because, as I mentioned, IVIG is itself hemolytic, we can't give this all at once. So we drizzle this in over a 5-day period, especially in the people who are not blood group O. So they can get a little bit worse before they get better because of the intrinsically hemolytic effects of IVIG. But what high dose IVIG ultimately does, when you add up the total of 2 gram per kilo from that 0.4 gram per kilo per day times 5 days, that 2 gram per kilo that person is getting super saturated with cools the immune system down. So it's this immunomodulatory kind of negative feedback reflex that tamps down an immune aggression activity such as hyperhemolysis. Okay, so this is a cartoon for what's happening in an acute hemolytic transfusion reaction. The patient here is rejecting your donor erythrocyte because there's an antigen that they find offensive. So they've got an antibody, an alloantibody against a donor alloantigen. You now know the answer to this question. It is true that you can hemolyze to death from a platelet transfusion or an IVIG infusion. And the cartoon here is this, okay? So this is a passive antibody coming in from your product and landing on a host antigen that the donor had immunity against, okay? So anti-A from IVIG can come into a group A host and cause hemolysis. Now, if you have a MAHA with thrombocytopenia, you have to think about whether or not they're coagulopathic or not coagulopathic. It's either DIC or a vascular malformation event versus a TTP-like pathology. So HUS, TTP, HELP, some endotheliotoxic and antineoplastics. Certain platelet inhibitors can cause fragmentation states, and calcineurin inhibitors too, like tacrolimus or cyclosporin. We defined Evans syndrome earlier. Evans syndrome is classically a DAT positive immune hemolysis with ITP. Okay, Evans syndrome showing up that way will give itself away with that positive DAT. Now I want to say a little bit about steroids because these are not something that you can stop quickly in immune hemolysis. People with autoimmune hemoligonemia, like people with lupus, need steroids for the long haul. So we're talking about a 6 to 12 month course of therapy. And the taper has to be very kind of stealthy. So you're trying to convince the immune system that they're still on steroids. So we are literally titrating by nominal milligrams so that you don't get immune flashback from the de-repression or the opportunity to hemolyze once again. So not like your COPD taper. Now let's flip over to ITP. So these are immune-mediated platelet counts that are less than 100. Most ITPs are idiopathic, 80%, but 20% of the time it could be a driver condition like lupus, antiphospholipid syndrome, common variable immunodeficiency, CLL, ALPS, HIV, Hep C, H. pylori, a post-vaccine phenomenon, or other infections. And we have 3 different phases by which to describe ITP. And severe ITP is if the patient's presentation comes with bleeding that requires major intervention. So your diagnosis of exclusion is ITP. We don't have tests by which to rule it in. I mentioned earlier that there is no DAT equivalent for platelets, but you have to take a patient history, a family history, look at the CBC. The MPV may be big and fluffy because this is megakaryocytic thrombocytopenia. This is post-production platelet clearance, and so the marrow may be trying to compensate, and young platelets tend to be larger than old stale platelets. So just as macrocytes or a higher MCV may reflect a reticulocytic compensation for hemolysis, a high MPV thrombocytopenia may be your surrogate indicator of compensation. And you'll see that on the blood film. You want to make sure you don't have an artifact or that you're not miscalling this because pseudothrombocytopenia might just be from antibodies against EDTA in the test tube. And so we do citrated CBCs to make sure that this is not an EDTA artifactual phenomenon. You run coags to make sure your thrombocytopenia is not a DIC presentation. The blood bank wants a sample in ITP patients so that we're ready to transfuse them if they need it, and so that we can do a DAT to make sure they're not co-presenting with Evans. Your immune globulin immunoquantitation is us looking to see if there are humoral immune deficiencies that may reflect in an immune deficiency state that's prone to ITP. Haptoglobin to make sure you're not hemolyzing an HIV test if they have a risk factor for it, okay, because HIV can present with ITP. So you want to get the patient on antiretrovirals. That may get rid of the ITP problem actually. So very important to identify this. Obviously, it's good for the patient to know that they have this so that you can treat it and so that you can not spread it to others. The liver is to the platelet what the kidney is to the red cell. So the kidney makes EPO, the liver makes TPO or thrombopoietin. So liver disease can be a cause of underproduction thrombocytopenia because you're not making as much thrombopoietin. And viral infections of the liver can cause ITP through that route or in their own right, particularly for hepatitis C. It's very important to test for these two viral hepatitides if you are working up thrombocytopenia or suspect ITP, because the treatment of ITP can also reactivate Hep B. So this is a quality of care issue. If we're throwing megadoses of steroids or about to give off-label rituximab to ITP, you better be sure that you know your patient's HBV status because they will need antiretrovirals to mitigate the risk of reactivation. Now, certain strains of H. pylori can cause ITP, and therefore the solution to those are to just do H. pylori eradication. Unfortunately, the CAG serogroups that cause this kind of ITP tend to be in East Asia and Japan in particular. So we tend not to see the flavor of H. pylori that goes away with H. pylori eradication, but often we say no harm done. So look for an H. pylori seroconversion because this may be an eradication treatable ITP. All the things on the right in gray are not basic evaluation or guideline-based tests, but you can explore them if you think they're of use. So they're not necessary, but they are optional. And obviously these are more expensive and sophisticated tests, so we don't recommend that they be done in all thrombocytopenia presentations, but sometimes we do these. Now, we don't typically transfuse platelets even if the platelet count is 1 or 0. If the patient is not bleeding, the most important thing is platelet count enhancing therapy by quelling autoimmune destruction. Because if the patient is rejecting their own platelets, they may be rejecting the product anyway. Okay, so we reserve platelet transfusions for serious life or limb threatening bleeding. So don't do this casually. A patient who's prone to making platelet autoantibodies may also be prone to seroconverting to platelet alloantigens and becoming platelet transfusion refractory down the line. So we want to be very conservative with platelet triggering. Now I mentioned that IVIG can cause hemolysis, okay, and it is second-line treatment of ITP. So again, a third will hemolyze after IVIG who are getting high-dose therapy and who are not blood group O, and a third of that third will hemolyze severely. So this really should be part of the informed consent, because a third of a third is about 10% of people. So that's a substantial enough risk that we should articulate that at the time of consent. Now, an alternative to IVIG to immunomodulate a patient is Rh immune globulin, Winro or Rogam, usually what we give to Rh negative gestations to immunoprophylax against D seroconversion. In this case, we're giving this deliberately to D positive people, which means you are getting anti-D landing on D positive red cells. Of course, you might get a little bit of hemolysis from this tactic. That'll occur in 1 in 1,000 to 1 in 10,000 patients, and it can be severe, and so there's a black box warning. And it has made this mode of treatment very unpopular for ITP, though this is very time efficient. You're not getting IVIG over hours and hours over a 2-day course, but rather getting a very quick, multi-minute injection with a low volume, not going to cause taco, not going to use up a bed for days or an outpatient infusion unit for hours. But it does have this black box warning. So many guidelines have been published on ITP, and the core of them is that you tailor your treatment to the patient. Your goal is to prevent bleeding, not to achieve a renormalized platelet count, because that may be unrealistic and the treatments may be more toxic than the risk of certain platelet count ranges. So you learn the counts that your patients bleed at. So this establishes a very close relationship between the hematologist and the patient if you're seeing ITP on an outpatient basis at clinic. You really want to avoid using drugs that add further platelet inhibition. So we sometimes prune off aspirin or non-steroidal anti-inflammatories, though sometimes that might not be possible in some cases. For example, those who've just had a coronary artery stent put in. I want you to appreciate that ITP is a thrombohemorrhagic paradox. Not only is it a bleeding risk disorder, but it can also induce thrombi. So we do suffer this tension with thrombocytopenic patients who develop blood clots that then need treatment. And so this is why heme consults gets called. And I'm sure you'll get exposed to rock and a hard place situations more than once. So this is the step ladder for treatment for ITP. Everybody hates steroids. Splenectomy can cure this condition, and it can also cure immune hemolysis, but it's getting less and less popular as we have more and more drugs to play with. And many of the immune suppressants are off-label when we use these in ITP, but they can control your patient's condition and get them off of those steroids that they hate taking. Rituximab off-label can put your patient into a long-term remission where they don't have to keep taking drugs every day too. So these are serious considerations. And ultimately, you can resort to, in this case, on-label treatment. TPO receptor agonists were actually invented for ITP. It seems kind of funny to do this. This would be like giving erythropoietin to a hemolyzer, but this is really to get megakaryopoiesis to achieve a positive balance and a better platelet count range, irrespective of how much immune storm is going on in the background. So obviously this is not getting rid of the antibodies or tamping down the antiplatelet antibody repertoire. It's just forcing you to achieve a different net platelet count. So ITP is pathogenesis-directed therapy in the front line. Don't forget to use your adjuncts if you're bleeding, your tranexamic acid, topical treatments, fibrin sealants, platelet transfusions if desperate. Sometimes we do acute presentation splenectomies, especially if the patient is looking ultra refractory in the first few days of treatment and they're starting to develop intracranial bleeding. This may be a life-saving maneuver, but we tend to save splenectomy for people who are chronic ITP or who've had it for longer than a year, because clearly treatment isn't working by that point. And, the glucocorticoid patient is suffering many sequelae, and so we are reaching for these off-label drugs. So, uh, immune suppressant, disease-modifying anti-rheumatic drugs, anti-rejection drugs, immune suppressant therapies used in transplant patients. We could be using oncotherapies, certain lymphoma-type chemotherapies we're borrowing from, and certain biologics. So the devil's in the details, and this is a hard condition to cure. So this is a reference table of different interventions, the dosing, the relative response rates, and the adverse effects. Two thrombopoietin receptor agonists on the market. So there's an oral option, eltrombopag, and a subcutaneous injection you can take once a week, romuplastim. Either of these regimens on a weekly basis amount to thousands of dollars per week, and the Ministry of Health will not reimburse the cost of this medication until the patient's gone through 5 circles of hell. That is, they failed steroids, they failed an intravenous immunomodulator like IVIG or Rh immunoglobulin, they've failed 2 steroid-sparing agents, and they've gone through a splenectomy. And that's hard to do. And it could take about a year before the patient's gone through those 5 circles of hell. So even though many guideline bodies promote the use of this on-label drug, third line, it's too expensive for patients to afford. Many private insurance plans don't cover it, and the Ministry of Health doesn't kick in until the patient's gone through a lot more. And so guideline bodies, many expert consensus folks will say TPO receptor agonists are favored over the maneuver of splenectomy, which induces a permanent immune defect, increases your patient's lifetime risk of overwhelming post-splenectomy sepsis. We chase them with vaccinations to mitigate that risk. TPO receptor agonists are favored over rituximab, but really in our healthcare system, this is a grab for whatever you can get compassionate access to. It's also the safest of these 3 options. So we've been trying to campaign with the Ministry of Health, and we have not heard back on a yielding on the criteria it takes to access this medication. So good luck to us, but you're going to suffer with your staff as you go through that treatment pipeline for the best and safest treatment for your patient. These are the platelet antigen systems expressed on a platelet. The ABO system is expressed on platelet, HLA, as I mentioned, and the different platelet glycoproteins. And these are the things that can be under attack in ITP or PTP. So when someone has ITP, usually what the platelet autoantibody is landing on is glycoprotein 2b3a, but some of the time it lands on glycoprotein 1b9. So if you were ever curious about what ITP is attacking, that's the lesion. So we've covered platelet transfusion refractoriness from HLA at the very beginning of the talk. So this accounts for 80 to 90% of platelet transfusion refractoriness, and the remainder are HPA sensitizations, which can manifest in the syndrome of PTP, post-transfusion purpura. This doesn't really respond to steroids, and so we need to use IVIG or apheresis to treat PTP. So if you suspect PTP, you really want to advocate for your patient and get them on the right treatment. And include a PTP if you are suspecting ITP at the beginning and they have no response to platelets, is to think about the possibility that your patient may actually have PTP and not ITP, because it does have a different treatment and it will change your management. Now, a few words on alloimmune injuries. Again, directions of incompatibility. Alloimmune injuries are classified as major or minor. Major incompatibility is essentially your patient is recognizing an input as a foreign alien, and it's their immune system that's doing the fighting work. And so it's a bit of an egocentric mnemonic. In minor incompatibility, the host is the innocent bystander, and it's something from the outside coming in that's doing the harm. And so some examples of major incompatibility are when a host rejects their red cell transfusion and has an acute hemolytic transfusion reaction, or if they're rejecting a transplant. And minor examples of incompatibility are those yellow stuff scenarios. So a platelet transfusion hemolyzing the host, or transfusion-associated graft versus host disease. Nothing minor about that. It's got a case fatality rate of 90%, hence the minor is in quotation marks. Trolley is immunologically an example of a minor incompatibility polarity. And finally, some words on TAGVHD, which was discussed at the very beginning. We mitigate this by irradiating cellular blood products. This is a proliferative engraftment of viable lymphocytes that mounts an attack against virtually every HLA-expressing tissue in the host, explaining the marrow burn of pancytopenia, fevers, rashes, hepatic dysfunction, diarrhea, and death in 90%. Rescuing these patients ultimately requires reseeding the bone marrow with stem cells. So that's essentially a bone marrow transplant. And I've never seen anyone survive this condition. It is very rare. It's a 1 in a million event. But we're a very big hospital that's transfused more than 1 million products. So if anything like this is going to happen, it's here. So I will conclude with 2 more points. And to summarize all of this, so immune heme disturbances account for almost all autoimmune hematologic cytopenias, as well as, and what I'm saying here is don't forget about alloimmune processes too. Okay, so don't forget about things like PTP or TAGVHD or trollogenic antibodies. So the alloimmune problems may be the cause of the cytopenia you're being asked to consult upon. Autoimmune states are also generally steroid responsive events, but if you have a steroid non-responsive state, again, I want you to think of alloimmune. So if you have any questions, please send me an email and follow up. And I thank you for listening to this presentation, and I hope that this was useful for you. And I do look forward to your questions if you have any. So all the best to you, and I hope you enjoy your hematology rotation.